Good afternoon, everybody. I'm really delighted that you're joining us for today's Healthy Neighbourhoods report launch. I'm Hannah Gibbs and I'm Head of Partnerships and Services here at Future of London. For anyone who's new to us, Future of London is the capital's independent network for regeneration, housing, infrastructure and economic development practitioners. And we help build better cities through knowledge, networks and leadership. So today's launch is the final event in Future of London's Healthy Neighbourhoods Working Together programme. And it's the culmination of an 8-month research and events programme. This whole programme's been possible thanks to our brilliant sponsors, Montague Evans, Mount Anvil and Pollard Thomas Edwards. I'll tell you a little bit more about the report shortly, but I'm going to start with a bit of housekeeping. And firstly, in case you hadn't noticed, I want to let you know that we're recording today's session and it's going to be up on our YouTube channel not long after the event. So I'd like to make today as interactive as possible within the bounds of an online webinar. So if you haven't already, it'd be great if you can just rename yourselves with your full name and organisation so we know who we've got here. And please say hello in the chat. It's really great for us to know kind of why you're here, what you're interested in today. And feel free to use that to put in any resources you think that people might find helpful or any reflections on what we're discussing. One of the key areas of focus for this programme has been on language and communication. So I think it's really important today to be aware of that. And if there are any terms or phrases that come up that you need clarification on, just say that in the chat as well. And we can come to it later on. There's also a Q&A function. Feel free to put in questions for our panel at any time, and we'll come to those in the Q&A session. And you can follow the event on Twitter with our hashtag healthy places. I also want to let you know that I've got a bit of a cough and I may have a coughing fit at any point. I'm absolutely fine. I'm quite well. I've just got a tickly cough. So apologies if it's distracting at any time. Okay, so just on to today's agenda. I'm going to start by outlining some of the key findings from our work and a bit of a flavour of the recommendations of the report. We're then going to hear from two brilliant speakers. We've got Dan Barrett, who's director at Thrive London, and Merron Simpson, chief executive of the Health Creation Alliance. And they're really going to bring the report recommendations to life and give us a sense of the implications for working with the health sector, as well as some tools and best practice that we can all use. There'll be time for questions, as I mentioned. And then before we round up, there's going to be a little bit of information from our Head of Knowledge, Anna, about the programme for Future of London for 2022 and what we've got coming up. And we'll be done by 3:30 at the absolute latest. So to tell you a little bit about the report and the programme. So Healthy Neighbourhoods Working Together set out to help the built environment sector play its role in responding to the COVID-19 pandemic and the broader health crisis we face. We really sought to go beyond the question of what makes a healthy neighbourhood. We know there's already a lot of information out there on the principles of healthy design and placemaking, and that across sectors we already do have quite a good appreciation of the link between place and well-being. But what we sometimes struggle with is building partnerships with the right health colleagues and at the right times and getting those partnerships to be effective. So we've been focusing on how to create productive collaborations between the health and built environment sectors in order to make healthy neighbourhoods the norm across London and other cities. So we've held a mixture of online and in-person events, including our first ever international field trip to New York, sadly virtual. And across these events and through our research, we've been looking at the challenges, we've heard about and unpicked best practice, and we've tried to develop shared solutions to the issues. So what we've really revealed is that the built environment and health sectors face difficulties when understanding each other's structures, our drivers and motivations, and our decision-making processes. And we have looked at a series of key barriers that we think are facing the health and built environments collaboration. So those are different timescales and boundaries, geographical boundaries that we work across, a lack of shared language, and the need for us to broaden the case for health beyond those who traditionally do health work. We've also found some shared challenges that affect both sectors, which we think could be opportunities for better collaboration if they're addressed in the right way. And these shared challenges are stretched budgets and resources, and the need for us to rebuild trust with our communities. So the report brings all of this together and provides some practical ideas for creating effective partnerships, drawing on examples and case studies that we've come across during the research and the events. So I'm just going to go through these key themes and give you just a bit of a sense of some of the recommendations and a flavour for the case studies and the evidence that we found. So starting with the missed opportunities and inefficacies that are caused by the health and built environment sectors, setting plans at different times for different time periods and across different geographical boundaries. Now, we know it's not likely that suddenly we're going to all start working on exactly the same patch of land. But we do think that part of this issue is because the built environment sector doesn't know who to contact and when it comes to health. So we're suggesting, rather than trying to get your head fully round the complex and often changing structure of the health sector, you focus on developing key contacts, people who are well-connected decision makers and budget holders. Develop relationships with them and ask them to kind of open doors for you, introduce you to others. There are some resources in the report which kind of outline the structure of the NHS and the health sector in London, and that also go through some of the key motivations of key stakeholders of the NHS, public health and social care. So that gives you that baseline, but we think it's about not getting too hung up on those structures and trying to keep up to date, and instead building those relationships. We're suggesting also that it's really important for the health and well-being of our citizens if we're able to synchronise place and health strategies, and where possible, putting these together at the same time or for the same time period so that we can maximise efficiency towards our shared goals. And if this isn't realistic, make sure at the very least that you've got people who work in health involved when you're putting together a master plan or a local plan or some kind of spatial strategy. Moving on to poor communication in sectors due to jargon and terminology that simply gets lost in translation. In the report, we've got a table of problematic words or terms that we are aware of that we need to kind of break down, we need to address if we're going to break down these communication barriers. It's really important that when a partnership comes together, you create shared definitions of what you mean by terms like community, which can otherwise be vague or confusing. These are really good principles generally when it comes to partnerships, but especially with these two sectors who can misunderstand each other. And we think that rather than just adopting the culture of one dominant partner when you set up a new initiative or project, it's really important that at the beginning of any kind of arrangement, you set a shared culture. So you come together, set your principles of your partnership at the outset, and create a culture also where it's okay to speak up if you don't understand something. Now, the need to broaden the case is all about how we find ways to encourage those beyond health to play their role in addressing health issues. Our Parks for Health case study in the report outlines how park staff in the London boroughs of Islington and Camden, through their programme, have become really excited and really engaged with the role they can play in supporting residents to be healthier. So, for example, they've worked to improve accessibility and inclusivity of their parks by expanding toilet provision and also re-evaluating public transport access to their green spaces. Park staff now support voluntary organisations locally to deliver activities that have a health and wellbeing benefit, so things like health walks and nature conservation. It's a really great example that you can read more about in the report, and I think it's something we can all learn from when it comes to broadening the case for health. Moving on to these shared challenges now, and this one relates to the challenges faced by the NHS and other health colleagues in the face of acute pressure brought about by the pandemic, on top of other long-standing issues. And this challenge is to some extent shared by the built environment sector. We're suggesting building partnerships to take advantage of larger and more strategic funding opportunities which are out there, but also the importance of maximising use of existing assets and the health benefits that they can bring. Another case study from the report is the Havelock estate in Ealing, where Catalyst Housing, the Canal and River Trust, and the London Borough of Ealing, as well as some other partners, have come together with a shared vision to improve health outcomes. In a neighbourhood where 43% of residents said that they do less than 30 minutes of physical activity a week, they have identified that the canal and the towpath can really act as somewhere for people to get some exercise, be close to nature, socialise, and do all sorts of good things, positive things for their health. So the partners have worked together to improve the physical state of the canal, improve access, and also done all sorts of community engagement to maximise the use of the canal and towpath to get people active. And finally, addressing the deep-rooted issues within communities, and particularly deprived communities, who feel let down and left behind by those in authority, which can be common to those in regeneration as well as in health. So we heard from the New York City Housing Authority on NYCHA in our virtual field trip, the importance of letting the community define their own health priorities. So part of their approach is to make residents community health leaders. So they train them through partnerships, such as with the local hospital, provide them skills and get them to lead on setting health objectives for the area, having those conversations with people locally and coming up with ideas and making them happen. NYCHA reminded us that there's no quick fix to building up positive working relationships with people who feel disillusioned or let down. So it's important that we make the time for meaningful processes where those involved are actually going to see some real benefit. And I know that Merron is going to touch on these themes shortly. So I hope that's given you a bit of a sense of what's in the report and the findings and some ideas for you to consider your own role in addressing health inequalities. I am now going to hand over to Dan Barrett, who is Director of Thrive London, and he is going to reflect on the implications of our findings on London's mental health. Over to you, Dan.
Thanks, Hannah. Yeah, I'm Dan. I'm the Director of Mental Health. If people aren't familiar with Thrive London, it's a public mental partnership supported by the Mayor of London and London Health Board partners. I've obviously had an opportunity to read the report ahead of today's event. And as Hannah said, I was just invited to say a little bit about implications for mental health. I think the overall report is great. It's full of great case studies, work happening in London that I had no idea about, and some really practical recommendations as well. And I'm just going to focus on what are for me some key points, 3 key points around mental health, but also looking forward to the Q&A later and what people ask then about mental health. So as noted in the report, healthcare only accounts for 10% of the population's health, while the rest is shaped by socioeconomic factors. Our mental health is no different, and is influenced by a whole range of factors, the circumstances in which we are born, grow, live, work, and age. These either enable us to thrive or they don't. Before the pandemic, mental health was already a significant challenge for London, with the prevalence of poor mental health often disproportionately higher in communities facing other entrenched inequalities. And there's substantial evidence that the pandemic has simultaneously widened pre-existing inequalities whilst creating new ones, including within mental health. Whilst it's too soon still to determine the full impact of the pandemic on the mental health of Londoners, it's clear the effects are both significant and multifaceted. And I think the first thing I latched onto in the report is the broadening the case for health, and an acknowledgement that many still associate the term health with a description of a sector or service, not an attribute that is constrained and influenced by our environment and life opportunities. And we see the exact same in mental health. And I think there's a need to shift public consistent conversations towards an understanding of a wellbeing economy and a rights-focused approach, how we maximise opportunities to improve Londoners' well-being. To do this require effort from lots of different sectors, lots of different people. And through the Mental Health Recovery Mission, which is a programme of work for London work on, we're hoping to contribute to this effort. The mission is an acknowledgement of the role many of us play, and all of us could play in supporting each other's mental health. And we're using the mission as an opportunity to educate people about the factors that shape our well-being and how we can take direct action to influence those. So For example, we're working with Councillor Davey in Lambeth to deliver training to councillors around how they can use local government powers and influence to create mentally healthier environments for their residents. We've so far trained, I think, over 200 councillors across 20 London boroughs, and we're very keen to continue to scale this programme, but also to work with other sectors to develop equivalent programmes of work around how we can all use the powers and influence we have to make better decisions to create mentally healthier environments. I think the second thing that kind of really struck me about the report was the focus on community engagement. And I know Merron will talk about this more, so I'm only going to touch upon it lightly here. But we know that participation directly addresses the marginalisation and powerlessness caused by inequalities. And we also know that it's good for our well-being. And so, you know, I think there's a real need to focus on how we harness the huge participatory energy that has happened as a result of the pandemic, not least supporting the vaccination rollout, and how we can harness that to support well-being. You know, participation is a core enabler within Thrive London. For an example of that, we have a programme called Right to Thrive, which is a collection of projects, partnerships and activities and grants developed with and for racialised and minoritized groups in London to support their mental health and well-being. And then there's loads of great examples of work like this at different levels in London. So like South London Listens, which, as the name suggests, is a project from South London in which they held group conversations and kind of community meetings with more than 6,000 people across South London to develop a shared action plan around mental health. I think as much as we can focus on that link between participation and mental health, the better, really. And I think the last one is around the role of ICS, or the role of the system, I suppose. You know, the health sector, as acknowledged in the report, is complex, it's ever-changing. There's huge amounts of change happening at the moment. You know, whilst this can create uncertainty and can be very challenging to work with, I think there are real opportunities within the reforms that are taking effect now. And I think there's huge opportunities to work with ICS around the built environment and how it can improve people's mental health. The Centre for Mental Health have done some great work in this area. I think they've developed a number of papers around how ICSs can create mentally healthier communities. And, you know, we know what is an ideal mentally healthy environment for people. It's having a decent home, it's having access to green spaces, to public transport, to high quality employment or training opportunities, free affordable pro-social spaces. And I think with ICSs, what we'll see, or what we definitely will see, is the creation of place-based partnerships and local care networks. And I think there's lots of opportunities within there to look at how those partnerships and networks involve a broad range of sectors to come together to improve mental health at a population level. I think to help with that, it would be really important to develop and kind of implement further mental health and policy type initiatives and tools and frameworks. So if you look at the Prevention Call Out for Better Mental Health, which is a piece of work led by the Office of Health Improvement and Disparities, it's developed a whole framework about how different sectors can make decisions and powers to influence people's mental health. And I think seeing the adoption of those types of frameworks within ICS and across different sectors will help to make this more of a reality. And with that, Hannah, I'm going to pause.
Brilliant. Thanks, Dan. Can I just ask you to say a quick word on ICSs, because some of our audience may not know what they are, and just kind of outline how that's a bit of a change in approach before we get on to Merron. Thanks.
Yeah, I mean, I'll do my best. So yeah, integrated care system. So in London, commissioning of health services was within clinical commissioning groups. So there's a clinical commissioning group within every London borough, and what the health and social care reform is adopting is integrated care systems. So in London there'll be 5, and effectively they're collections of boroughs, and so there'll be an integrated health board, but also an integrated care partnership working at a sub-regional level in London. So northwest, northeast, north central, southeast, and southwest. And so those structures are in place, but from a legislation point of view, I think they're due to go live formally in July. So there's lots of consideration at the moment, within my role, but very broadly across the health and social care sector, within public health and other arenas, around the kind of role of integrated care systems in improving the health of Londoners over, the foreseeable future.
That's great, thank you. And I think something that we mentioned in the report is that integrated systems, integrated care systems likely to be more place-based than the previous. So for the built environment, there is a real opportunity to kind of have conversations in a way that it's used to. So yeah, thanks very much for that, Dan. And I think often for the built environment, the sort of physical health stuff is really quick to our minds because we think a lot about active travel and how we create places that are sociable. So I think it's really important to highlight that mental health angle. And thanks for giving us some sort of frameworks and tools to think about. Be fab if you can add some stuff to the chat of some of the things you referenced. Okay, I'm going to move on to Merron now, and just a reminder that you can pop questions for the panel at any time into the Q&A, so we can have a look at them before we get to that section. So Merron is going to focus on health and health creating neighbourhoods, and building on the report recommendations to talk about community ownership and give us a few sort of practical ideas of how we can work with communities on health priorities.
Thank you, Hannah. So I'm Merron Simpson, and I'm Chief Executive of an organisation called the Health Creation Alliance. We're the leading national cross-sector movement addressing health inequalities through health creation. My own background is in housing, and I spent over 10 years influencing housing and in fact planning policy at the national level. But over the last 8 years, I've been much more dedicated to helping the NHS to connect and work with the various place partners. And that's why we're cross-sector. So local authorities, housing, the VCSE sector, and in particular communities themselves and people with lived experience of disadvantage, housing, childhood trauma, mental ill health, discrimination and poverty. And helping them to address health inequalities through health creation. So helping all our members to do that. So I'm a bit of a sector bridger. And what I find is that bringing insight together across many sectors is actually, although it's immensely difficult, it's actually also immensely powerful. And it's really worth doing. And I think, I've been doing this for 8 years, but now is the time to be trying to do this. So I really like the report. And I like the focus on how to build productive relationships rather than simply focusing on what makes a healthy neighbourhood, because we do know a lot about that now and we have a good evidence base around that. But it's actually the lack of connection and relationships that prevent us from getting on and building healthy neighbourhoods, and perhaps one or two other things as well. But that is a key barrier. I like the recommendations very much. They're really practical and I think they will make a difference. The barriers, the different timescales and boundaries, geographical boundaries, that is, the lack of a shared language and the need to broaden that case. These are all very familiar things and they bubble up all over the place. So I'm sure you've all experienced these difficult. I also find that there are many unknown unknowns in the health sector and in the NHS in particular. So unknowns about what you guys are doing, what's happening outside the surgery door, outside the hospital door, and also a huge clinical workload, which obviously has become bigger through COVID, and the lack of leadership as well, actually, although that is starting to change, but clinical leadership is what is most important in the NHS, but it's a different type of leadership. And so that difficulty has been part of the prevention, if you like, or the slowness of significant progress being made in terms of building healthy neighbourhoods. But I do think that now is a really good moment, and this is starting to change. We are getting new leaders, and I've heard I was at an event 2 days ago, Primary Care Improvers Group, and I heard people talking in ways that I have never heard them talking before, about how we need to build a vision together with others outside the NHS, and how we need to develop that language and that understanding, all sorts of things coming out of that. So it is starting to change. And of course, where it's been working, it's due to progressive partnerships. So breaking down the barriers and having an impact despite the limited budget. And I would put the Health Creation Alliance in that category. We're a progressive alliance across the UK dedicated to finding solutions that work and spreading them despite the very limited budget around this work. So we'd be delighted to get to know more of you. I think I know some of you already, but to get to know more of you. But the report sets out these challenges as well: stretched budgets and the need to rebuild trust with communities. And I would like to just focus in on the last of these: need to rebuild trust with communities. And it dawned on me, I wondered if we could start to see that, not so much as a challenge or a shared challenge, but as a shared ambition or opportunity. So perhaps reframe the challenge around the community and rebuilding trust as a shared ambition and opportunity. And that's a question to you, really. Would that be something that we'd, perhaps a shared opportunity with the health sector? Is that something that could bring the two sectors together? Building trust is just the first step to something much bigger, and that can have a much bigger impact on the health of communities. And we're talking about mental health, but also physical health. We call this bigger thing health creation. And I'll explain that a bit more in a moment. But our ambition as an alliance, as an organisation, is to make health creation business as usual across the whole system. And this includes the way the built environment works. So elements of health creation are happening all over the place. So you can see bits of this, and it is very patchy though, particularly when you've been used to working in the NHS side of the fence, if you like. And part of the reason it's patchy, I think, is because we haven't really had a construct around health creation or what it is that makes people well. We've been focused on treating illness, preventing illness, but what about creating health, a third pillar of what the health system and care system needs to be, but in its broadest sense. And of course, it doesn't have a profile or status yet in policy and systems, although we've been working on that and we are seeing progress. And it's not an explicit part of how we do things. And health creation is often overridden by economic and political forces, let's be honest about that. But I just point to a few examples. The planning system is highly consultative. Master planning, neighbourhood planning, these are excellent examples of mechanisms that communities can use to take control, but the trust levels have to be there in the first place. And it's often the affluent communities who already have high levels of individual and collective agency and who know how these things work that are most able to use them. Physical regeneration is often, I find, out of step with community regeneration. We've seemed to have lost the connection, if there ever was one. There has been a connection in some places, and we know that it has and can work. My favourite example perhaps is Castle Vale in Birmingham, because I live in Birmingham, but other places like Waltham Forest, the Housing Action Trust 20 odd years ago, they're great examples of where physical and community regeneration were done hand in hand, and the community was engaged at every stage. And indeed, particularly, I know in Castle Vale, there was a resident-led neighbourhood board that made the decisions about how that physical regeneration would take place, and that developed over time. And in another example, I met a community that was developing what might be called interim uses. They were using a site where homes had been demolished, and were using it for a range of community purposes. And they were really enjoying using that space, but they were facing new buildings being built on that site. And they felt they had no control over what that was going to be used for. Now, that may have been part of a long-term plan, but they weren't either being helped to source other places and other options for continuing those activities. So these are some areas where, we know that consultation is part of planning and what we do, but it's patchy. And it doesn't work always for the least, those communities with least agency. So I've got two questions. One is, how might working meaningfully with communities, including the more disadvantaged communities, be reframed as an ambition or an opportunity? And how might we do that and at the same time build a health creation infrastructure around this activity so it stands a chance of affecting systems change and becoming business as usual? Well, I'm going to ask for the slides to be put up now because the Health Creation Alliance has developed a framework for health creation. And in fact, we've developed 2 frameworks and we could probably do more because there's not just one framing of this, but it will help to unpack this. And the power of the frameworks is in their simplicity. So they are simple. And I think and we've been told by others that there is a potential for a shared framework and shared language. They offer a lot of flexibility and room for conversations in how we achieve that. So if you go to the next slide, please. So health creation is, our definition, the process through which individuals and communities gain a sense of purpose, hope, mastery and control over their own lives and immediate environment. And when this happens, their health and well-being is enhanced. And if you go to the next slide, that's right. So there is a process for health creation, again, very simplified, but it works. And it's well evidenced that building meaningful and constructive contact and connections between people and within communities helps to build agency and increases confidence to take action. And that leads to greater control. So that's a route to gaining greater control over people, for people to gain that control over their lives and to some degree the determinants of their health as well. People need an adequate income, a suitable home, an engaging occupation and a meaningful future, of course, but these things are linked. So as agency is developed, we can start to see how this wider determinants of health and those structural inequalities can be dealt with better. And having control over our lives and environments is proven to enhance health. And it really can help with, even when people are finding themselves in difficult situations, it helps to improve their ability to cope with those things. So the main message here, we talk about the 3 C's of health creation: contact, confidence and control. And if we go to the next slide, the main message is that taking control improves health. I tried to take the word back out of this slide, but I couldn't. And I hope it doesn't sound too much like a Dominic Cummings kind of an approach. It's not meant to at all. It's not that kind of taking control that we're talking about here. But nevertheless, it is health creating. And if we go on to the next slide, we have developed this framework which professionals can use and do use to create the conditions for health creation by working as equal partners with people and communities. Sorry, if you just mind going back to the slide before. And focusing on what matters to them and their communities. And there are 6 features of health creating practices, and we derive these from talking to communities whose health had improved significantly and talking to the people that live there and the people that worked with them to make that change happen. And we asked them what was the most important thing in improving your health. And they, over and over and over again, through a process of several years, we've refined these. We actually added reciprocity recently because but the other 5 have been around in our in our manifesto for at least 5 years, and we work with these routinely. And they are listening and responding. So responding to what you hear, truth telling, which is ultimately the foundation of trust building, a strengths focus. So what's focusing on the asset of the community, not them as a deficit on what's wrong. Self-organizing or connecting people, developing that collective agency. Power shifting or power sharing, really, really important as part of this. And reciprocity. So people are willing to give a lot, but they do want something in return. And if they don't just want to receive stuff, they want to give back as well. So there has to be some two-way flow there. And if that reciprocity isn't there, it builds resentment in places. And that's what's behind some of this difficulty with the trust. And over time, that's been eroded. So these features of health creating practices really are, at the sharp end, that where the rubber hits the road, if you like, at the front line in terms of how we can help to create health. And health creation is enabled. We need people in communities, but also professionals to be practicing these routinely and building systems that enable that to be practiced at the front line. We need places to, be these principles to be built into places. Policies, we love health creation in all policies. Everyone wants their thing in all policies, whether it's health, mental health, health creation. But let's see if we could agree to something, because I think that health creation is a really good way of putting that when we think it should come through in everything. And power sharing, again, really important. Just one more slide before I stop for sort of questions and pose some questions as well. Another framing we did about this time last year was talking again to people who had been working with communities to support them in various ways. And we came up with a different framing. It's the same actually, but it's slightly different elements to it, which is fine. We call it digging deeper, because you need to dig deep to understand what it is that really matters to people and that creates that health. And it really does, it reduces A&E attendances, it reduces GP appointments. It really can be life-changing for people. And essentially, people need to be connected. That's really core. They need to be connected to other people, but they really need to be connected to their passions and what it is that, to themselves as well. And we see this when people have had really traumatic experiences, they become kind of disassociated from themselves as well. So there's an element there about enabling people to be connected in many ways. People need space, and I think this is really key and core and should be of great interest to built environment professionals. They need physical space to connect, and we're learning more and more about how communities feel more confident meeting in their spaces. So social prescribers, even GPs, etc., need to think about where they're expecting people to go and whose space they're expecting them to step into. But actually, people also need emotional space as well to reflect and to do that hard work of gaining, of getting that control, if you like, back in their lives. System space to take action. So we need, the system not to bear down on people and do everything for people and make the decisions, but enable them to play a role in that. And then people need to employ and enjoy their skills and passions. This is all about the strengths focus, really. And we all need to do a little bit of what we love doing, don't we? And find the time for that. That might be also part of what helps people to build esteem, passing on skills to others, feeling you've got something to offer and to give back. And that helps people to take control. So self-organizing, making requests, learning new skills, taking action, making the right things happen to benefit themselves, their communities and places. So getting involved with things like neighbourhood planning and master planning. And this is really what happens before that happens. So this is that difficult space. And if we don't engage with this stuff, we will drive greater inequality because people will be stuck and not connected. They won't have the space, they won't be employing their skills and passions, and they won't be taking control. And so all of this is in the public domain. You can look on our website, and it's on the in publication, in various publications. So I guess coming back now to kind of, we've been digging deeper, and if you go to the next slide, just coming back to kind of the here and now, and what can we do with with the built environment, connecting health and everything. I did wonder whether meaningful work with communities, and including those that have low levels of collective agency in disadvantaged places, could be reframed as a shared ambition and opportunity, and whether this is something that could bring those sectors together. We certainly cross-sector, and we have this as our principal thing that we're trying to get adopted across all the sectors. Could having a common focus on creating health help to bring the health and built environments together? What might a health creating approach to, say, regeneration look like? We know already, actually, we've got that, Castle Vale, Waltham Forest and others, but we also have some very poor examples ongoing right now, and I could name some of them, but I won't. And what's driving that? Is it the viability of the sites? Is it the economics? Is it the politics? Yes, quite possibly, but what might we do if we want to get back to enabling, things being done for local people with local people? And how can health creation be embedded into the built environment processes to routinely create healthy neighbourhoods? And how might the infrastructure for health creation be developed from this, not just the physical infrastructure, but the process infrastructure, because this is a process and it's an ongoing process. Thank you very much, and I look forward to the panel discussion and the Q&A.
Thanks, Merron. That's absolutely brilliant. And just so many parallels, I think, with built environment and regeneration work. I can see some really sort of useful principles and framing there for those of us who work on place-based projects. So thank you for that. We are going to move to Q&A now. So do pop your questions into the Q&A function at the bottom. And yeah, I was going to invite Dan to put his camera back on, and he just has. I am going to start, if that's okay. I want to just pick up quickly on something that Merron said. The thing around helping health colleagues understand what's going on beyond the surgery door, and really conscious of the pressures that everybody is under. How do you think, what's the sort of most useful way that built environment professionals can do that in a way that takes account the sort of capacity and resource issues within health? Merron, I was thinking you would go first, but
I'm just getting my head around the question, and what's the best way? Gosh, I mean, look, this is hard, the truth is I decided to jump over the fence into the NHS. I got an invitation to join an organisation called the NHS Alliance that had been involved in it was GP led, and that was the forerunner to the Health Creation Alliance, because it didn't feel as though the NHS was going to be able to make that, build those relationships without it coming from the NHS. And actually what Dan was talking about earlier with the current shifts that are happening in the health sector to integrated care systems, and the integrated white paper and the legals behind that, that's not an overnight thing. That's been quite a long time in coming, but that is essentially, all those papers are being written essentially by the NHS with local government involved, rather than the other way around. And I think that it became apparently obvious to me that if we were going to really engage, it was going to have to build out from the NHS and lead them to, build confidence to talking to people outside the surgery door en masse. I mean, there are, health professionals that do that and have been doing that. So I guess, this is a really good opportunity, and there are many opportunities now. When it comes to capacity, we've been doing work around primary care, and one of the key things we've been highlighting to NHS England is that the relationship building is not costed into the model of the NHS at any level, and it's not, there isn't a language of relationship building, and there isn't the capacity to do it. And we've been trying to find specific mechanisms, like through additional roles reimbursement scheme, which is something that primary care now is doing. But they can only employ social prescribers and not built environment, and not relationship builders. So we wanted, particularly relationship building posts to be employed by the NHS. However, we are now feeding into the fuller review of primary care. Claire Fuller, a GP, and I think an ICS lead in Surrey, is leading that, and we have seen another opportunity, and NHS England is now engaging on this point. So I think that it's fair to say that across the NHS, people are seeing this, and they are in any case starting to fund posts to connect to. Often the VCSE sector actually is the principal place that is being mentioned in the NHS, but I think the built environment is hugely important, and we've been very keen for housing to be involved, and others. So I'll stop there, but I think the capacity thing, I think it is coming, and just be really mindful that your clinicians are under real stress and strain at the moment, but there are some, build those relationships where you can.
And I just wanted to pick up there on social prescribing. That's something that we talk a bit about in the report, and I am aware that it's not necessarily common knowledge within the built environment sector what that means, but it's sometimes known as community referral, and it's basically a means where a GP can refer somebody to a community activity that's not clinical. So it might be a walk, or it might be some kind of social club, so that with the idea being that it promotes more holistic health, but it also takes pressure off the sort of primary care. And I think, to answer my own question, we found that can be a good tool for sort of getting a conversation going between, you know, particularly housing associations who seem well placed to do that sort of work. Dan, I don't know if you had any reflections on the first question, or I have another one for you if not.
Yeah, I mean, I'll be quite brief, you know, because I think Merron's covered it really well. I think there's a few key things from my point of view. I think it is really challenging to understand how decisions are made. Like, I work for the NHS and I find it challenging myself. And I think there's a real need for the health service system to do more to educate people about how decisions are made. You know, I think that's kind of point one. And I think there's a need to raise expectation around democratic accountability of health and social care services is the kind of flip side of it, and the people who make decisions. And last thing, one of the things I've put in the chat is, I appreciate I just put loads of links in the chat, which isn't perhaps helpful, but the second from bottom one is a paper that was presented at the London Health Board yesterday, which you know, it's a public meeting, the papers are public, but it's a paper written collectively by a number of senior leaders in London around the development of integrated care systems in London and their priorities over the coming months. And you know, if people don't mind reading those sorts of documents, I think it's well worth reading, because it sets out quite clearly, in my opinion, some principles and some priorities around ICS operations in London. And I think, you know, I was mindful of that when I was speaking about where I think there are opportunities for, you know, other sectors to get involved in influencing decisions that will improve people's health.
Brilliant, thank you. Okay, I'm going to go to a question from the audience. We don't have your name, unfortunately, but it's a great question, and is going to be quite a big question, I think, for Merron and Dan, which is, how do you see the levelling up strategy with the white paper that was recently published playing into building healthy communities? And I don't know if you've both managed to read it cover to cover, but wondering if you have some reflections. Who's brave enough to go first with that?
I'll have a go at it. I think, I mean, there are these 10, what are they, targets? No, missions, that's it. 12 missions, aren't there? And I haven't got them in front of me right now. So I'm not going to talk specifically about each of them. They looked quite good, you know, and I know that lots of the paper looks quite good. And I know that, you know, essentially the big barrier and the big problem with the paper is the lack of resources. So, you know, only probably 1 or 2% of the amount that's really required to do the levelling up is going to be made available. So, with that in mind, bearing in mind that you know, the resources are absent really, or at the level that is required to do the levelling up as envisaged, you know, or as we'd really like to do. I'm just going to quickly look at the question again, because it's, yeah, how does it play into built environment? I think that essentially the built environment, you know, it's all about the money, isn't it? Ultimately, and the you know, the money, the viability of sites, the land prices, etc., drives all of these things. And I don't see, unless I'm, you know, sort of not noticed it, I haven't seen that being discussed or debated much in the levelling up paper. So I think it's going to have, I don't think it's going to have a huge impact on the built environment, and you know, I think that's going to still be you know, be expected to the other drivers are going to be too big, let's say. for this time. And the other thing is that the levelling up agenda, it's not really about levelling up. It's about sort of boosting every place, if you like, or making sure all boats rise. Not all places are starting in the same place. So I think there's something really misfiring in this paper, and I'm not sure how. It's certainly the other thing that's a bit absent is that I don't think it's really talking about levelling up, individual places at a small level. It's kind of across the whole country, and looking at regions, and devolution is likely to come out of it in a significant way. We see transport and we see housing significantly in some of the devolution, not so much housing, but in some of the devolution deals and what's happening in those mayoral combined authorities. So, who knows whether that, I don't see it happening in a big way yet, or at any time in the near future. I just don't think it's going to really pull through, I'm afraid. But I do think that if we collectively start focusing on how we can work with some of those more disadvantaged communities in a different way, that will actually help to start to level up. And that's why we're quite keen to keep going with this health creation agenda, because I think some of the answers do lie more at the hyper-local level than at that level of infrastructure.
Yeah, absolutely. I think as well, one of our case studies actually from Islington in the report qualifies that point, and it relates to Pollard Thomas Edwards, who've done a series of projects in an area which have gradually had a really positive impact on health and well-being. And I think it's important to sort of think about that local neighbourhood scale in all this. Dan, do you have any thoughts on the white paper?
Yeah, I mean, I think it's definitely going to have an impact on the public health system. Not just the levelling up paper, but other white papers around integrational papers due to come out later this year. So I think there's a need to take stock of it and consider it. But what I'm hopeful is that it opens up, from my perspective, I think it opens up opportunities in mental health around cross-government working. And around looking at the wider determinants, looking at mental health and all policies. And so although, yeah, there are some reservations with it at this stage, I think we will, it should hopefully lead to more opportunities around taking that health and all policies or mental health and all policies approach.
Brilliant, thank you. Okay, I've got a question from Bav Shah, who's from Montague Evans, who are one of the sponsors of this programme. And she says, thank you for inviting Montague Evans to sponsor and participate. She says, in her experience, excuse me, there's that cough, as I'm about to say, COVID-19. In her experience, COVID-19 has fast-forwarded relationship creation, both within the NHS and the public sector. So has Merron and Dan seen a shift in thinking from stakeholders towards their organisations, and have you benefited from this? And do you think, excuse me, do you think this will be a meaningful shift in the long term? So really it's about have new relationships formed as a result that will stick around. I know, Merron, actually it might have been Dan, so one of you did touch on that. Dan, perhaps you'd like to go first.
Yeah, I mean, the short answer is yes, hopefully it will do. My own role changed significantly during the pandemic, and what Thrive London was asked by health departments to do during the pandemic significantly changed. I think there was a really strong acknowledgement of the mental health impact of the pandemic right in the early days, and there was a clear direction from leaders in London to needing to focus on mental health within all the other priorities that health sector and local authorities in particular were having to focus on. So I think I've seen a lot of efforts around integration over the past 2 years, and that it's really accelerated in that area. And a huge focus on trying not to lose all the good work of the past few years. And I think the other thing that I've really seen happen, both in my work, but also just through speaking to lots of colleagues, particularly local government, public health colleagues, is just much stronger relationships with communities themselves, I think, and much more efforts around working with communities to design and deliver activities to support pandemic efforts. And I think, you know, as I mentioned, I think there's a need to, in some ways it's understandable, like it's a public response to a crisis, like people are going to be more willing to participate and do their bit. You know, I think the trick is to understand the motivators for that and how we can work with people over the longer term to continue to harness that participatory energy. And I know that myself and lots of people, many people on this you know, webinar are involved in developing work in that area.
Yeah, that's great. Yeah, it's all about maintaining the momentum. Merron, any thoughts?
Yes, just a little bit. I think it has changed things hugely in terms of the health sector. I think there were two phases to this for them. One was the rapid response at the beginning of the pandemic, and they kind of watched as their, you know, as individuals, as their sort of elderly relatives and people they knew were helped by community groups that kind of self-organized and mobilized very, very quickly. And that was probably the first time for some people working in the NHS that they'd really realized that this was a possibility, or that this was, you know, a thing, and what might be possible through that. And then the second sort of wave of that was the vaccination rollout, where, you know, I think almost everywhere, in the end, GPs and other health professionals that were involved in that vaccination rollout realized that they're only going to get the numbers up if they worked with communities and went to the community spaces to deliver those vaccines. So it has been a huge kind of educate, you know, very, very quick education. But the other thing is that there was a lot of kind of you know, unfreezing, if you like, and refreezing of, or not refreezing hopefully yet, but new relationships were built. And we talked to some people who were really struggling, say, with, you know, let's say there was one example where there was a development trust who was doing social prescribing, but they weren't able to get the management fee that went along with that. They could only pay for the social prescribers themselves. They were making it up with a grant, and they'd been having conversations with the primary care network for some months saying, we need this extra money, we need this extra money. During the pandemic, it just happened. And they were basically saying all these conversations just, you know, they got bolder, and the conversations got more fluid, and things happened between the meetings. And yes, new relationships and new understanding was forged. And I think that is permanent, actually. Well, for the foreseeable future. I do think that it sort of coincided with a shift to realizing how out of touch we'd become as a society, how much inequalities had increased. And if you're aware of Professor Michael Marmot's work, you'll know about all of that. I think it, you know, we're doing a project at the moment for NHS property services, and we're exploring what it is that makes the biggest difference to different types of communities, in terms of when it comes to making spaces available for community wellbeing or social prescribing, but we're trying to broaden that into community wellbeing more generally. And they're really, really interested in really understanding how to go and talk to people when they go to a place to, you know, develop or redevelop the building or premises. And they are genuinely interested in learning through this process, and we're, you know, delighted to be helping them. So I think that people are looking to forge new relationships and find new ways of doing that. And, you know, we're delighted that this is happening. It's a bit of a tsunami, but I think, you know, I really do hope it will continue in the longer term. We do need to kind of, you know, try and make it business as usual while we've got this moment in time.
Yeah, it does just feel like such an opportunity, doesn't it? And really quite an exciting moment to sort of do things differently where everyone's open to that. Okay, I've got a question from Tristan Dewhurst, who says he's very interested by the discussions about community capacity and dialogue and trust and control, and is wondering how you think this applies locally to sort of controversial interventions like low traffic neighbourhoods, where arguably there are tensions between agencies and communities. And I suppose, yeah, the point is it's quite easy to think about how these processes can be nice when you're sort of starting from something nice, but how can they work when you're starting from something that involves tension? Who wants to go first?
I mean, I have a brief reflection, and then Merron's probably more experienced than Sarah and I am. But I don't know the point in front of me, but I think the example from Camden, I think it was, around the role of citizens' assemblies in working with assemblies to set the priorities for a local area, not just consult on predefined priorities. This is a really good example of how those in power can set up their participatory process in a way whereby they're mindful of the issues that local residents may or may not support more. And so I think it goes back to needing to go further with our kind of participatory process, whereby we're not just consulting on predefined ideas or kind of priorities, we're working with those residents to set those priorities. And I know it can be a contentious topic for certain boroughs, and that's not necessarily going to stop the decisions that others will make, but it hopefully assures more residents that local authorities, others, health services and others are making decisions based on what local residents see as important.
Yeah. Merron.
Thank you. Right, contentious issues are difficult, so I'm not suggesting that all the answers are there in every case, but I do think that the facilitation of the conversation can make a big difference to the outcome. People want to be heard, and they want to know that they've been heard, and they want a response. If the answer's no, they're happier that they've had their say and been heard, and even if it wasn't the outcome they wanted. And so the process again is what really matters here. And you can't please all the people all the time, but you can look at maximising the different aspects and feeding that back. And people will often focus on the project, naturally, because we can see a project. I've forgotten what LTN stands for, local traffic.
Low traffic neighbourhoods.
Low traffic neighbourhoods. Yeah. So that was visible, and it happened just overnight, didn't it? And I'm sure everyone has been frustrated at some point by a flower box popping up in the middle of the road they used to drive down. So that's the project. Let's stick the flower boxes in the road, and but actually, if we'd focused on the uses, how do people want to use the streets, and had a conversation around that, recognizing that you can't have both, no traffic streets for children to play in, and rush hour traffic coming through at the same time. Recognizing there are trade-offs and working with that. I think that is part of the solution. Certainly, I've done work with the LGA before on new housing, and how do you get communities to agree to new housing? And when that process is led really well, you usually find many fewer barriers to that new housing than you would when it's not led very well. So it's again about the leadership skills. I would focus again on the 6 features, on looking at listening to people and responding to them, even if the answer's no. Being honest about this, about what's possible, seeing if the community has any ideas themselves. That's the strength element. The reciprocity thing. So we can't give you that now, but is there something else we could do? The example I gave you where the community had taken over a space which was for interim uses while some physical regeneration was going on. That community really needed some attention from the public, from the built environment colleagues around them, professionals around them, to work out how they could do what they wanted to do, because that was important to them. They didn't necessarily need to use that space, but they needed something. So it's about uses, it's about focusing on what people actually want to do, not on the projects and on the leadership around that.
Yeah, and I think, like you say, the process is so important, and we've heard countless stories about people just need transparency. They need to know what the options are, and they're happy to be, like you say, they're happy to be told we can't do that because of this reason, and here's what we're suggesting instead. People respond well to that. Okay, we've got 3 more questions, which I'd really like to be able to get to all of them. So we might have to be a little bit succinct. I've got a question on health impact assessments, which I think I'm going to ask to Dan, and then I've got one for Merron about the role of housing associations. So yeah, Dan, so Lizzie Wood has asked, do you think that health impact assessments are appropriate tools to assess the positive and negative impacts of development on the health of different groups?
Broadly, yes. You know, so within Thrive London, we particularly focus on equality impact assessment tools within our work. And I think as long as the health impact assessment tools have a kind of robust way in which to understand inequalities, how they're experienced, how they're exacerbated through decisions, then they can be a useful tool.
Yeah, something we mentioned in the report as well is that there are different tools for doing it and that are appropriate for different schemes and different levels. So it's kind of important to pick the right one for your setting. And then Merron, we've had a question from Sheena Street, who's from Southern Housing, and she's saying they're really interested in accelerating their contributions to health creation, and how can housing providers best place themselves to do that with partners. I mean, it seems to me, as I said earlier, that housing associations are really well placed for this sort of work.
Indeed, and we, you know, I got involved with the NHS Alliance originally 8 years ago because you know, I was trying to help to forge good relationships between housing and health, both housing associations and other housing providers and local authority housing as well. And we did a number of projects on that, supported by housing associations largely. So I would say become a member of the Health Creation Alliance, but obviously you're asking the question in a different way and in your setting. And there are actually, I think that there is an understanding now that housing has a huge, a huge part to play in all of this. I used to go to housing and health events that were attended mainly by housing people, that were run by housing organisations, but now I am sort of pleasantly surprised to find the King's Fund running health and housing events. And I think locally, it all depends on what people are doing around you, but we have got a report called Shining a Spotlight on Housing, and it applies the health creation framework to housing. And we actually invented a sort of a diagnostic from that as well. So we have, we do have quite a bit of experience of this. There are many ways. I mean, I could go into some of them. We're talking here about help with with people with mental health problems, for example. Dan will know about this. Sometimes they have a home and sometimes they lose a home through that process. So how can housing associations can step in that respect, and provide accommodation as well as some of the wraparound care. I think when it comes to homelessness, there's a much greater understanding, and I was hearing Jill Lang speak just the other day on this, that peer-led elements, peer-led services, so people who've been homeless, running homeless services and being part of the infrastructure and being paid to do that is part of health creation and part of improving our services. And this is the case all over the place. So there are many ways that housing can be involved in all sorts of ways. We used to have a website on it actually called Housing for Health, but unfortunately it got very out of date and we had to stop that. But I'd love to do some more work on this. So I would be really up for talking to the housing providers, housing associations and others to see how we might move forward on some of these questions. So thanks for the question, and I hope I've answered it reasonably well, but happy to have another conversation afterwards.
Absolutely, that's great. We can put anybody in touch as well if use us as a conduit if you want to be introduced. Okay, I think we've got 2 questions left. So the first is from Liz Zacharias at Campbell Tickell, who says that integrated care systems have great potential to drive health in housing, but it's been a bit ad hoc or based on kind of interested or passionate individuals. So are there any kind of top tips, I suppose, of how we can make it more intentional and the norm?
I mean, I think a lot of this is still emergent and evolving, to be honest. You know, I think, you know, ICSs are in place, but they're still maturing. And so I think behaviours and intentions will change over time. I think the key thing to understand it is around the level, I guess, the level at which to target, I think, in a sense, like ICSs are, in a sense, and independent of each other. They try, you know, can try and make broad decisions about the whole of London, but at the end of the day, it's about serving their population in their area. And I think demonstrating an understanding of their population and making the case relevant to the sub-region or the kind of local area, it will become more important.
Yeah, and I think one of the things which I'll come on to saying, but I think it's about built environment, people going proactively to integrated care systems and saying, like, we've got a way to solve some of your problems, and kind of doing it that way. In the interest of time, I'm going to ask Merron to respond really quickly to that one.
Sure. Okay. So I agree. It's been ad hoc and probably will continue to be, because housing's got such a lot to offer, and it depends on trying to match it to what the health sector is looking for at that particular time, because they look at things much more narrowly and reductively, and that's quite a hard process. I would say don't get overwrought about the evidence, because people tend to go for things when they're being told to do them. There's a white paper that was out on the 9th of February, another integrated care white paper about joining up, and it does mention housing in that. So housing is being mentioned in these top level documents now. I think that when I said don't get too hung up about the evidence, there is nevertheless this thing called population health management coming through, mainly driven through public health, which is very evidence and data led, and you might want to start trying to get the housing data into that. I know a number of places where they're coalescing their evidence, which includes housing data around things like condition of homes, etc., into those data sets, and and working with them together. So I think it's fair to say that that white paper that I mentioned is on the 9th of February. It's about what's called place level, which is roughly speaking local authority level. And so ICS level is above that, but there is very much a focus on getting these arrangements, cross-sector arrangements, set at the place level as well, and also potentially the neighbourhood level through sort of primary care networks on the NHS side, but broader than that. So this is very much, it's in process, this whole new architecture, but there are opportunities, and maybe now is the time to revisit that.
Yeah, and again, I think whilst they are in, coming to fruition, now is a really great time to sort of set up those links. Okay, I hate to do this because this is a huge question to end on, and we've only really got a couple of minutes to do it. But Matthew Hill is asking, and sort of building on the discussion about low traffic neighbourhoods, what can we do to link the radical change that we need to make built environment and transport systems meet our zero carbon goals with the public health agenda? Yeah, and I'm sorry, you've not got long, so maybe just one idea each of something that we could sort of quite practically do to link those two agendas.
Yeah, so, I think we're starting to see the mental health impact of the climate crisis. There's London studies around at the moment. So for me, it is an intersectional issue. Thrive London does research around climate change and mental health and how we join up those different agendas. So I think there's an area there. I think the other area is there's a huge focus in health around air quality, which is obviously only one part of responding to the climate emergency. But I think there are big partnerships and big coalitions that could be formed between different sectors that are creating environments that are less toxic.
And Merron?
Thanks. I'm going to focus on poor condition housing. You might expect me to. Putting insulation in, renewable energy sources, this sort of thing. We've got a real situation with bills increasing, gas prices going up. It's going to really throw a lot of people into even more poverty. And rather than give the money to the big, the energy companies, really I think there needs to be a big lobby to get that put into actual homes and targeted through probably through the benefit system at low-income households that are in poor condition homes, that are cold, that are leaky, that aren't very climate friendly, and put the money in the right place. So I think there needs to be a really big movement around this. There are places doing it so well, and we need to start looking at those places and saying, how can we do this everywhere? This has to be the change model. Here's where it really works. How can we do this everywhere? And sort of get behind it as a movement, really. I'm quite keen on movements. And I would say this is one, I think there is a movement actually doing this, but well, there is, we've seen them on television, haven't we? But I think this is ultimately, I can understand why they're taking the sort of radical action that they are. Perhaps the built environment could come up with their version of this and really get behind a sort of powerful movement.
Yeah, so there's a kind of joint lobbying role for health and built environment to play. Okay, thank you ever so much for everyone's questions, and to Dan and Merron for giving us some really brilliant ideas there. So I'm sure everyone would like to join me in saying thanks to Dan and Merron for their time and their presentations. I'm going to end on some key lessons from the report and a few things for you to sort of take away. Fran, if you could just share that final slide. Just some things I'd like you to sort of bear in mind as you consider how to step up and play your own role in addressing health inequalities. So the first I sort of touched on earlier, it's around being proactive. So come to the table with an offer. Instead of asking health colleagues for support, ask them what they need and how your project can scheme or organisation can support their objectives, particularly in the context of immense busyness. Look at solving financial issues creatively. So all sectors are facing stretched budgets and resources, and solutions can be found through cross-sector partnerships, and especially for those bigger joint opportunities. As I've mentioned, it's about focusing on those key relationships with budget holders that you can collaborate with, rather than trying to sort of keep up to date with every nuance and change in the sector. And finally, get people excited about it. And we know that we've got a huge role to play as built environment professionals in supporting our communities to be more healthy. So let's think about how we can write it into job roles and make it part of our projects and schemes. Like Merron said, everybody wants their thing to be in all policies, but why not? So that's pretty much it from me. I want to say a final thank you to our sponsors, Montague Evans, Mount Anvil and Pollard Thomas Edwards. And thanks again to our speakers, and also a quick thanks to the Future of London team who are behind the scenes, making sure everything runs smoothly. So thanks, Fran, Nicola and Anna. Please do download the report. Should be sharing another link of it soon, and you'll get an email. And we'd love to know what you think, and do sort of share it with colleagues.